Robert was 73 years old, a retired civil engineer from Georgia, and by every reasonable measure he was in good health. No symptoms, no urinary problems worth mentioning, no family history that placed him in any elevated risk category beyond what was simply average for a man his age. His annual physical was routine: blood pressure, cholesterol, a few standard panels. And at the end of it, his doctor ordered a PSA test, the same way he had for the past 8 years. The result came back elevated. Not dramatically, just above the threshold that triggers the next conversation. His doctor recommended a biopsy. Robert was not told that elevated PSA at 73 is extraordinarily common and frequently reflects nothing more than the benign prostatic enlargement that is present in over 70% of men his age. He was not told that the United States Preventive Services Task Force, the most authoritative evidence-based medicine body in the country, had issued a Grade D recommendation against routine PSA screening for men in his age group, meaning the evidence showed that potential harms outweigh potential benefits. He was not shown the data from the Prostate trial, published in the New England Journal of Medicine, demonstrating that at 10-year follow-up there was no statistically significant difference in prostate cancer mortality between men who chose surgery, radiation, or active surveillance for low to intermediate risk prostate cancer. What Robert was told was that his number was high and he should find out why. So he agreed to the biopsy. The biopsy found a Gleason 6 tumor, the lowest grade, slowest growing category of prostate cancer. Multiple oncologists would later confirm that this tumor, in a 73-year-old man with Robert's life expectancy, fell squarely in the category that poses minimal mortality risk and can be safely monitored with active surveillance. But Robert's urologist recommended treatment, and Robert, hearing the word cancer, chose surgery. 6 months after his radical prostatectomy, Robert wore incontinence pads every day. He had not had an erection since the procedure. The cancer that was treated would almost certainly never have caused his death. The treatment that addressed it changed the quality of every year he had remaining. My name is James Calloway. I am not a urologist. I am not an oncologist. I am an independent health researcher who has spent over a decade reviewing the peer-reviewed literature on health outcomes for adults over 65, and the data on PSA screening in men over 70 is among the clearest, most consistent, and most systematically ignored bodies of evidence I have encountered in all of that reading. The cascade that starts with one routine blood test, a cascade that cost Robert his continence and his sexual function, is documented, named, and understood in the medical literature. It is called the PSA cascade, and it is still happening to hundreds of thousands of men over 70 every single year, because no one has time in a 15-minute appointment to walk through what the numbers actually show. If your doctor has recommended a PSA test, if you have already had one that came back elevated, or if you are currently navigating a prostate cancer diagnosis made through routine screening, I need you to watch this entire video before you make another decision. The link in the description and in the pinned comment below connects to a natural prostate support formula built around the compounds with actual clinical evidence for prostate health in men over 70. But first, the data. All of it. The PSA test has a sensitivity of approximately 80% for prostate cancer detection. What is almost never communicated alongside that number is the specificity, which sits around 30% in men over 70. That means 70% of elevated PSA results in this age group do not indicate cancer. They indicate benign prostatic hyperplasia, prostate inflammation, recent physical activity, recent sexual activity, or simply the normal tissue changes of an aging gland. 70%. That is the number sitting behind every elevated PSA result in a man over 70 before a single biopsy needle has been introduced. When a biopsy is performed, and in most clinical settings, an elevated PSA leads directly to a biopsy recommendation, the procedure itself carries risks that are substantially elevated in men over 70 compared to younger patients. Post-biopsy sepsis, bloodstream infection from bacteria introduced during the transrectal procedure, occurs in approximately 1 to 4% of cases. In a large 2013 study published in the Journal of Urology, Hospitalization within 30 days of prostate biopsy occurred in 9% of men, a figure that rises with age. Urinary retention requiring catheterization affects up to 5% of biopsy patients. Significant rectal and urinary bleeding, erectile dysfunction, and anxiety related to the diagnosis experience itself are all documented complications. These are not rare edge cases. They are the statistically expected outcomes for a meaningful percentage of the men who undergo this procedure every year. When the biopsy finds cancer, and autopsy studies published in JAMA and the British Journal of Urology International consistently show that 40 to 60% of men over 70 have histological prostate cancer present that they were never aware of and that never became clinically significant. The diagnosis produces something well documented in the medical literature. Treatment: convergence under anxiety. Despite active surveillance being a guideline-endorsed equivalent to treatment for low-risk prostate cancer, the majority of men diagnosed with prostate cancer, when given the choice, choose active treatment, not because the data supports it for their specific tumor grade and life expectancy, because the word cancer produces a decision-making environment in which waiting feels like giving up and treating feels like fighting. And the treatment, radical prostatectomy or radiation, produces permanent consequences that in the overdiagnosis scenario are not offset by any meaningful survival benefit. The USPSTF's calculation is stark. For every prostate cancer death prevented through PSA screening in men over 70, the evidence suggests that approximately 20 to 50 men are treated unnecessarily, experiencing the full burden of surgical or radiation side effects for a cancer that posed no actual threat to their lives. Urinary incontinence in 10 to 40% of prostatectomy patients, erectile dysfunction in 40 to 70%, bowel dysfunction, urinary irritation, and a small but real risk of radiation-induced secondary malignancy in radiation patients, bone density loss, cognitive changes, cardiovascular risk, and metabolic syndrome from hormone deprivation therapy. These are not the outcomes of failed treatment. These are the documented outcomes of successful treatment of a cancer that did not need to be treated. Now here is what the PSA cascade means for the majority of men over 70 who enter it, and why I would not get this test. It is not that prostate cancer is not real. It is not that prostate cancer cannot be serious. It is that the mathematics of this test change fundamentally after 70. A Gleason 6 tumor typically takes 10 to 15 years to progress to a clinically threatening stage. A 73-year-old American man has a median life expectancy of approximately 12 additional years. The statistical overlap between the time for this cancer to become dangerous and the time this man has remaining is so narrow that treating it Warrentura with all of its consequences produces at best marginal benefit and at worst a permanent reduction in the quality of every year that remains. The USPSTF understood this arithmetic. The Grade D recommendation is not a suggestion. It is the conclusion of a systematic evidence review by the most rigorous body of its kind. So what does proactive prostate health look like when it does not start with a blood test that triggers a cascade? It looks like addressing the biological mechanisms driving prostate enlargement, urinary dysfunction, and prostate cellular health from the inside without creating a diagnostic chain. Sao Palmetto has decades of clinical research showing improvement in urinary symptoms related to BPH. Beta-sitosterol, the plant sterol studied in multiple clinical trials, shows measurable improvement in urinary flow and symptom scores. Pygeum africanum bark extract has a Cochrane-reviewed evidence base for reducing nocturia frequency and improving bladder emptying. Lycopene, the carotenoid most concentrated in prostate tissue, is consistently associated with prostate cellular health in epidemiological research. Zinc, the mineral present in higher concentrations in healthy prostate tissue than any other organ in the body, is commonly deficient in men over 70 and essential for prostate cellular function. And physical activity, 30 minutes of walking most days, is the single most consistently protective behavioral factor in large cohort studies associated with lower rates of BPH symptom progression and lower PSA elevation rates independent of age. Before you leave this video, here are the exact questions I want you to bring to your next appointment if a PSA test is recommended. Ask your doctor, given that the USPSTF recommends against routine PSA screening for men my age, what specific factor in my history makes you believe the benefit outweighs the risk for me personally? If my PSA is elevated, what is the probability it reflects benign prostatic hyperplasia rather than malignancy? And how would we distinguish between the two before recommending a biopsy? If a biopsy finds a low-grade cancer, what is the evidence that treatment produces better prostate cancer mortality outcomes than active surveillance for a man my age? And what are the documented rates of urinary incontinence and erectile dysfunction for the surgical approach you would recommend? You walked into this video with one set of information. You are leaving with another. The link in the description and the pinned comment below connects to a natural prostate support formula built around the clinical evidence for prostate health in men over 70. No cascade, no biopsy, no consent form required. What comes next is your decision. But now you know what the numbers actually say.